BIPARK-I and BIPARK-II were the two pivotal study studying the efficacy of Opicapone, which is a COMT inhibitor in patients with Parkinson's disease and response fluctuations. The first study, BIPARK-I, had 600 participants and included not only placebo and different dosages of Opicapone, but also an active comparator, entacapone, which is also an COMT inhibitor and used to be standard of care for many years now. So we have three comparators: Opicapone, entacapone, and placebo. And the second trial was the BIPARK-II study, and this included only two different dosages of Opicapone compared to placebo, and had 427 participants. These were large studies with a lot of participants. There was a chance to do also some informative subgroup analysis. And what we presented in the present EAN Congress were two ways to consider subgroups of the BIPARK studies. The first analysis were done in patients with recent motor fluctuations, which is to say patients who experienced veering off or on-off motor fluctuations for a year or less, compared to those who already had motor fluctuations for a longer time. And it turned out that the clinical efficacy, the improvement of off time, was identical between the two subgroups. So this is strong evidence that Opicapone is also feasible and efficient in patients with beginning of response fluctuations. There was remarkable differences in the two subgroups with long and short duration motor fluctuations concerning dyskinesia. The patients who had long-standing response fluctuations for more than 1 year had far more often dyskinesias as a side effect of Opicapone treatment compared to those with recent fluctuations. Then another sub-analysis took a look at patients who received Opicapone as a first add-on to levodopa, namely patients who did not have other adjunctive medication, just such as MAO-B inhibitors or dopamine agonists. And again, the clinical efficacy and the was very similar to the overall sample, again adding evidence to the idea that Opicapone is feasible in early stages of response fluctuations in patients with Parkinson's. So the second sample that was taken in consideration in the sub-analysis were patients with dyskinesias, or patients in whom the levodopa dosage was reduced during the study. So in order to understand the protocol, patients were placed on Opicapone and could then be adjusted according to the dosage of levodopa afterwards. And this happened in a proportion of patients who experienced dyskinesias due to the improved availability of levodopa. Some patients had dyskinesias after being placed on Opicapone, and in some patients levodopa was even reduced before dyskinesias occurred, so let's say in a prophylactic way in order to avoid occurrence of dyskinesias. And now the sub-analysis took a look at those patients who had reduction of their levodopa dosage, and it turned out that the clinical effects, the improvement of off time, was not compromised by the reduction of levodopa after adding opicapone. And in those patients who had experienced dyskinesias, when they were given opicapone, the dyskinesias were abolished by the reduction of levodopa. So it's the main message concerning the tolerability is that if dyskinesias occur with the addition of opicapone, they can and should be managed by reducing the levodopa dosage.